ये मेरा माइक इसके लिए मैं एक्सटर्नल यूज़ कर रहा हूँ, कैमरा एक्सटर्नल यूज़ कर रहा हूँ।
बिल्कुल शॉप तो 2-3 बड़ा अच्छा करते हैं, लेकिन कैमरे की क्वालिटी जो है ना वो सारी बात है।
हाँ
कैमरा ये बहुत अच्छा है।
हाँ, ये कैमरे की क्वालिटी उसकी भी अच्छी है, लेकिन दिस इज़ फॉर मोर, इसका व्यू एक बहुत बड़ा है, उसका व्यू ज़रा कम है।
ये भी है।
हाँ सो
जब उसको आप थोड़ा सा पीछे ले जाए ना तो कर देता है काम को, लेकिन फिर आपको देखने में प्रॉब्लम
यस,
है कि मैंने भी पढ़ना है।
अब मैंने वहाँ से पढ़ना है।
हाँ बिल्कुल,
चलिए हम शुरू करते हैं।
थोड़ी देर देखूंगा सब कुछ।
शुरू करते हैं, ठीक है ठीक है। यू वांट द ACS, तुमने ACS पढ़ना है?
नहीं सर, मैंने ये सिस्टम देखना है, ये सिस्टम कैसे चल रहा है, फिर मैं देखूंगा। आज थिएटर है।
सो तुम लोग फिर पीछे बैठ गए हो जाके, ये सारी जगह खाली है, तुम्हें समझाया कि आगे बैठा करो आके। मेरे लिए चलना बहुत मुश्किल है, वहां तक सीढ़ियां चढ़ना तो बहुत मुश्किल है। सो आई वांट यू पीपल क्लोज टू मी। So now today we see acute coronary syndrome. In the last lecture we saw chronic stable angina, and now we see the other variant or other presentation of coronary artery disease, that is acute coronary syndrome. Now we see a case vignette. A 58-year-old male was brought to the emergency room with ongoing severe chest pain for last 1 hour. Last 1 hour, there was sweating. He was a smoker for last 25 years and was on amlodipine for 5 milligrams for hypertension. On the way, he vomited once. So now, what do you think this is? Clinically, what is this? Yes? Yeah, you're a doctor. What's heart attack? So the patient has myocardial infarction. What suggests that this is myocardial infarction? So chest pain is going for such a long time, 1 hour. Usually the angina settles down in few minutes, 5-10 minutes, it settles down. Unstable angina may persist, but if the pain persists beyond 30 minutes, consider the MI has occurred. So this patient possibly has an ACS. The provisional diagnosis is acute coronary syndrome. Now, what is acute coronary syndrome? It's an umbrella term used to cover a group of clinical symptoms compatible with acute myocardial ischemia. It has 3 variants. It's unstable angina. What is unstable angina? Every angina of recent onset within the past 2 months is an unstable angina. Angina which is present at rest is unstable angina. Crescendo angina, what does crescendo angina means? Angina coming with less and less effort. Suppose patient had an angina which would come after walking 500 meters. Now it has started coming after walking 200 meters. So this is crescendo angina. And then if you got post-myocardial infarction angina, this is again an unstable angina. So these are different varieties of unstable angina. It is recent onset angina, crescendo angina, angina at rest, and post-myocardial infarction angina. Next is NSTEMI, non-ST elevation MI. Myocardial infarction with ECG changes of ST depression, new T-wave inversion, and it is different from unstable angina in that in unstable angina you do not see the markers of myocardial necrosis, that is CPK or myoglobin or troponin is not elevated. Ladies, there's noise from your side. You? What's the problem with you? I've told you, you don't want mess. So the difference between unstable angina and the non-ST elevation MI is that there is myocardial necrosis in NSTEMI. In unstable anginas, there's still no myocardial necrosis. So you do not have that CPK, troponin, or myoglobin going up. While in NSTEMI, you will have abnormal enzymes. And then you've got ST elevation MI, myocardial infarction with persistent ST elevation. So you can have these 3 entities grouped into acute coronary syndrome. Now this is a little bit of events. What happens, the plaque gradually starts increasing, and in the end you see there's a clot on top of it, and it causes occlusion of the lumen. Before this usually is stable angina, but a clot develops on top of it, causes obstruction in the blood flow, and you can have the spectrum of unstable angina, STEMI or STEMI. Now, what will be your next step? What will you do? This patient has come to you in the emergency. You make a diagnosis that this patient has ACS. What will you do? Yes? Yes? What will be the first step? You will take in the patient. You will take in the patient. You admit him immediately. You do not discard this patient. Immediately admit him. This is basically a teamwork. Our team is carrying out diagnostics. The other team is going for the first aid. So get an IV line immediately. Give aspirin. The first thing you do is give patient aspirin, ask him to chew and swallow if this is not already done on the way. Because if you've got emergency ambulance services, they do this on the way. But if it's not been done, immediately give aspirin to chew and swallow, soluble aspirin. Patient who's got severe pain, morphine is the painkiller of choice, should be given morphine. The non-steroidal anti-inflammatory drugs should not be used as injectable painkillers in these patients. It should be morphine or some derivative of it, preferably morphine. Start facial oxygen with facial mask. Get an ECG and send the requisite labs. And what is the next most important step? Engage the cardiology team. Inform the cardiology team on premises that we have a patient. We should immediately inform the cardiology department that we have a patient. Now, this is the patient's ECG. What do you see in this ECG? So you see lead V1, V2, V3, almost V4. They are showing ST elevation and some spiking T waves. So the diagnosis is confirmed almost that this is acute ST elevation in the anterior wall. This is acute anterior wall MI. Now, the presentation of acute coronary syndrome depends upon these features: severity and duration of arterial obstruction, the volume of myocardium affected, what is the level of demand, and what is the health of the rest of the heart. For example, if the rest of the heart already has a damage and the patient develops MI, the presentation will be far more severe. So these factors determine how the patient is going to present. Now, what are the symptoms of ACS? Patient has characteristic pain, retrosternal pain, which is crushing in quality. Now, what happens in ACS? It can be brought on rest. Exercise is more intense, lasts longer than patients who got chronic stable angina. As I mentioned, the pain was going on for 1 hour. It means this patient had myocardial infarction. There may be palpitations, giddiness, diminished cardiac output, shortness of breath, heart failure, diaphoresis due to sympathetic discharge, nausea from vagal stimulation, and patient may have anger, anemia if the patient has developed acute through and through myocardial infarction. So this may be present. So these are the usual features. And the physicals, they include the patient may have hypotension, which can be checked, and patient usually has diaphoresis, the skin is cold and clammy. There may be hypertension because of the anxiety in some patients. So you do not actually treat this hypertension immediately until the patient's pain has settled. The blood pressure itself on its own comes down. So if you improve the anxiety, this comes down. Another important benefit you get from giving morphine is not only it's a painkiller, it's a very strong anxiolytic. It can also help if there is pulmonary edema. So this is a wonderful drug. So it can decrease the anxiety. The blood pressure may come down on its own. Patient may present with heart failure. There will be jugular distension. Third and fourth heart sound may be audible. Much of MR may be there. And you look for the presence of extra cardiac vascular disease. For example, history of stroke, or if the patient has intermittent complication and peripheral vascular disease. Now, physicals of your patient who came in. The vitals, the pulse was 110 per minute, blood pressure was 130/90, finger saturation on pulse oximeter was 94%. Skin was clammy and the patient was diaphoretic. JVP was flat. There was a fourth heart sound audible. There was no evidence of extra cardiac vascular disease. Peripheral pulses were all right. So these were the physicals. Now, what investigations are required for patients who present with ACS? ECG is the most important. Now, as I talked about ECG, it should always be serial. The first ECG may not show the changes of acute ischemia. So it has to be serial, and if a previous ECG is available, a comparison may help you a lot. So if the patient's record is available, compare the ECG with the previous ECGs. Is there any change in it? A change is always significant. There may be ST elevation, there may be ST depression, there may be T-wave inversion, depending upon it's an ST elevation MI, it's non-ST elevation MI, or it may be only angina. There may be Q waves. Yes? Serial ECG, it is determined actually by your clinical assessment. Usually, if the patient's condition is stable, we would like that we do it in half an hour, and we see half an hour, the changes, they appear. But if the patient deteriorates, you can have ECG immediately after minutes. So it really is determined by the patient's clinical situation. And patients may have arrhythmias. Now, other investigations include labs. Serial creatinine kinase, because creatinine kinase starts appearing in 4 to 6 hours. The patient has come with a pain of 1 hour. CPK will be normal. So you repeat it after 4 to 6 hours. You have a baseline CPK, and you repeat it, and you find CPK has increased. This means this is a new infarction. It peaks in 12 to 24 hours, and 24 hours to 48 hours starts disappearing. After 48 hours, you do not find CPK in the circulation until the patient has reinfarction. If the CPK is high after 48 hours of initial presentation, means there is a reinfarction. Troponin, they start coming in 4 to 8 hours. They remain there for 7 to 10 days. They've got prognostic and diagnostic value. They are pretty important. The larger the troponin, the larger the damage, the larger means the more severe disease in the prognosis comes bad. So it's something which determines prognosis. And then you can get myoglobin, which is not done these days. It starts coming after 2 hours. But it's not specific. It can come from other muscles as well. But a troponin which is negative at 4 to 6 hours, it means it has a very strong negative predictive value. If the troponin is not increased, this means the infarction has not occurred. So this has its own value, but it's no longer used for assessment. And then you go for complete blood count and routine panel like blood sugar, electrolytes, renal function, liver function, lipid panel. Lipid, we not because stress changes the profile. You need investigations. And then imaging, how sexy well, not like this patient is stable and transporting it into X-ray can cause trouble on the way. We do not need an X-ray for this patient. But bedside X-ray may tell us about the cardiac size, if there is pulmonary edema, if there is aneurysm with thoracic aorta, and if there is pneumonia in particular. So that is very important because pneumonia can worsen the patient's cardiac status. Bedside echocardiography may be useful. There may be regional wall motion abnormalities. What does this mean, regional wall motion abnormalities? When you see the contraction of the heart, you find out that a particular portion, a limited portion, is not in synchrony in contraction. The heart is contracting and it's going out. So this regional wall abnormalities means this is infarction. It can tell us about the LV function. It can tell us about the internal structures. How is the wall? How is the valve? Is there any pericardial effusion? And then perfusion imaging in some patients, it may be required. Perfusion imaging is very important because if it is negative, it has a very high negative predictive value. So this may be required in some patients, but generally we do not require. The data usually is sufficient to prove that the patient has ST elevation myocardial infarction. And then cardiac angiography defines coronary anatomy and extent of the disease. Cardiogenic shock is an indication when the systolic blood pressure is less than 90 millimeters of mercury. You've got intractable angina despite medication, severe pulmonary congestion, and right ventricular infarction. If these conditions are present, angiography becomes very, very important because it tells you that you may need a change in your plan for management of this patient. If these clinical situations are present, patient is hypertensive, there is ongoing angina, there is swelling, pulmonary congestion, or RV infarction, for angiography. Now, when a patient comes with symptoms of coronary artery disease, you see non-ST segment elevation. This can be unstable angina, cardiac enzyme will be normal. It can be anstemic, and you can have ST segment elevation. This means the patient has ST segment elevation by myocardial infarction. So this is a general outline of a plan when a patient comes with symptoms which are suggestive of coronary artery disease. Now, what will be your subsequent management of this patient? What will you do with this patient? You have taken IV line, you started oxygen, you give him aspirin, you given patient nitrates to relieve some pain. So what is your next one? Cath lab. Good. Facility of primary PCI available in your institution. If door to balloon time is less than 90 minutes, go for a primary PCI. If in-house facility is available, door to balloon time is 90 minutes or less, go for a PCI, a primary PCI. If the primary PCI not available, then what will you do? Patient can be transported to invasive setup. Transport if door to balloon time is less than 120 minutes. For example, it may take, say, an ambulance to maybe 10 minutes or 15 minutes to reach PIC, the other hospital where invasive setup is available. We have invasive setup in Mayo Hospital as well. But suppose if we don't have, it will require 15 minutes of transporting. Call the emergency team in the PIC that we are sending patient with the acute MI who's got about 75 minutes. When the patient reaches you, prepare for invasive procedure. So that time is 120 minutes. Patient cannot be transported to invasive setup. That means you need more time. Here you thrombolize with alteplase, tenecteplase, or streptokinase. Streptokinase is the last option. So use alteplase, tenecteplase, or streptokinase. Now your patient. Suppose facility of primary PCI not available and the nearest cardiac center is at 4 hours drive from your center. Patient is thrombolized and admitted. You admit the patient and you follow. And then what happens? Things are going all right. You start all these conventional treatments. And on post-admission, the patient develops a certain amount of shortness of breath. Things were going all right, and the patient became very short of breath all of a sudden. What has happened? He was diaphoretic, severely short of breath, orthopnic, cyanosed, and hypotensive. Now, what has happened? One? Why? Why the heart failure has developed? Chest was full of crepitation, and there was a new onset pan-systolic murmur audible with some difficulty in the precordium. What has happened? So either the mitral valve has gone, or there is a VSD. Mitral valve. Either the mitral valve has gone or there is VSD. A pan-systolic murmur is heard in both MR and VSD. So the patient has developed either of this, or one of this. Bedside echo may be very useful in making diagnosis. The possibilities include acute MR, acute VSD, reinfarction. Here you send CPK again. If you find on echo that there is no MR or there is no VSD, go for CPK. That will tell you, because troponin is not important at this stage, because it is a troponin with first infarction maybe still present in the circulation. So in the second infarction, you can't judge it's the same troponin. So CPK may be useful in this situation. As I said, that in case of reinfarction, CPK becomes very important. After second day, CPK rises again, means there is a second infarction. Now, what will be further management? High flow oxygen. Next. You may require even intubation. You will require diuretics if the patient is not very hypertensive. Dobutamine infusion, that's what you said is the inotropic support, or you may use noradrenaline. And then intra-aortic balloon counterpulsation. What is this intra-aortic balloon counterpulsation? You put a balloon in the aorta. Instantly, the balloon deflates. In the deflates causes movement of blood back into the coronary arteries, so improving the perfusion. So you may need this counterpulsation, and immediate surgical intervention may be required, the repair of the valve or the repair of the VSD or the replacement of the valve, whatever the cardiac surgeon thinks feasible. So you may require surgical intervention. Now, what are the complications of acute MI? Patient may have rhythm disturbances, premature ventricular contractions, ventricular tachycardias, ventricular fibrillations. In fact, the most serious complications are ventricular fibrillation and ventricular tachycardia. Which clinical presentation of acute myocardial infarction is the most serious? Which clinical presentation of acute myocardial infarction is the most serious presentation? This was a question asked by Professor Najmuddin Ansari from me in final professional exam. Is ventricular fibrillation a clinical presentation? It's your diagnosis. Clinical presentation is headache, vomiting, like that. So what clinical presentation is the most serious when there is an acute MI? Unconscious patient. If the patient has become unconscious, that means no blood is going into the central nervous system. That happens in ventricular fibrillation and when there is cardiac asystole or there is electromechanical dissociation. There is no pumping of the blood. So that is the most serious presentation. And if the patient becomes unconscious with an MI, you immediately see if this is ventricular fibrillation. So primary ventricular fibrillation generally has a good prognosis. If you can revert it, the patient is reverted. So secondary fibrillations may have a more serious outcomes, but this has got a good prognosis. So patient may have ventricular fibrillation, ventricular tachycardia. There may be atrial contractions, supraventricular tachycardia, atrial fibrillations, sinus bradycardia, third-degree heart block, when different type of bundle branch blocks. And then complications include papillary muscle rupture, that is acute MR, ventricular septal defect, right ventricular myocardial infarction, free wall rupture. This is again very, very serious complication. Free wall rupture means the blood is going to go into the pericardium, pericardial space, and is going to produce cardiac tamponade. So that has to be recognized immediately. That requires immediate action. You aspirate it or you open the chest and drain the clot and repair the cardiac wall, but that generally is very, very difficult. Most of the time when there is free wall rupture, the outcome is very, very guarded. Patient may develop cardiogenic shock. There may be recurrent angina, there may be recurrent MI, there may be pericarditis, acute pericarditis and chronic pericarditis, which is an autoimmune reaction called Dressler syndrome. The patient may have pericardial effusion and there may be pleural effusion as well. Patient may have pneumonia, pulmonary embolism. Why pulmonary embolism? Immobilization. And second reason? One is immobilization. Second is the patient's cardiac cardiac output is not good. So there is stagnation, stasis. Do you have any other idea? You were whispering in his ear. हाँ, बड़ा मासूम बन के उधर देखा ऐसे मैंने देखा ही नहीं है. हैं क्या इसके कान में क्या कह रहा था? कुछ तो कह रहा होगा ना? So patient may develop pulmonary embolism, but generally these patients are on anticoagulation. So developing pulmonary embolism is less likely because patients who have been thrombolized may be on heparin. But still, the patient is immobilized and pulmonary embolism is a real possibility. Shoulder hand syndrome is another chronic complication of acute myocardial infarction. Now, this is the general outline of treatment of acute coronary syndrome. Patient has ACS. Patient has unstable angina or non-ST elevation MI. You go for antiplatelets, anti-ischemics, or anticoagulant therapy. And then you plan PCI or CABG depending upon patient's subsequent investigations. And for STEMI, you go for antiplatelets, anti-ischemics, or anticoagulant therapy. You either go for thrombolysis or you go for primary PCI or CABG. And then there is long-term medical management. That is aspirin, beta blockers, ACE inhibitors, statins, lifestyle modifications, stopping the cessation of smoking and control of blood pressure, blood sugar, etc. Now, when you want to discharge the patient with acute myocardial infarction, how do you plan that I want to discharge this patient now? When will you discharge? No, the patient is symptom-free. There is no angina. Patient is vitally stable. Patient is not heart failure. There are no other complications present. Usually it is the 4th or 5th day we can discharge the patient. If the patient is very stable, sometimes you can discharge on the 3rd day as well. But it's generally safe to discharge on the 4th or 5th day. Now you go for secondary prevention, diet, exercise, weight control, smoking control, lipid control, beta blockers, ACE inhibitors, aspirin, statins, cardiac rehabilitation, discharge planning, go for a pre-discharge echo and stress test, and you see if there is residual symptomatic disease present or not. So these are the tests you conduct before you discharge the patient. And this is about the management of acute coronary syndrome. Do you have any questions or comments? None?